Let's learn about biliary atresia from Bailey, Sabiston and Schwartz. This is the most important topic for all examination. So we'll see all the points in bit detail. Okay. So biliary atresia affect male and female equally. Just remember, biliary atresia affect barabar in male and female, and colodocal cyst affect females mainly. You may get confused in exam. So biliary for barabar in male and female. Okay. It is a progressive disease and destroyed by an inflammatory process. So if it is untreated, death occur from liver failure before age of 3 years. Untreated, before death occur before age of 3 years. So there is a classification named as Japanese and Anglo-Saxon classification. This name can be direct one-liner. Anglo-Saxon classification for biliary atresia. So there are three types: type 1, type 2 and type 3. So how you can remember? In type 1 it is restricted to CBD, in type 2 it is common hepatic duct, and in type 3 it is right and left hepatic duct with and the entire extra hepatic biliary tree. And in type 2 there is a type 2A and 2B. So in B, gallbladder, cystic duct and CBD are also obliterated. In A, all these three structure will be present. So B is gallbladder, cystic duct and CBD obliterated. Okay. So clinical feature: 1/3 of the patient present jaundice at birth. Remember, only 1/3 present jaundice at birth, and all affected baby jaundice present by the end of first week. So in MCQ generally it given all the children present with jaundice at birth. Remember, it is just 1/3. By end of 1 week all the affected babies will have jaundice. Okay. And then stool are pale and urine is dark in color and pruritus is severe, and clubbing and skin xanthoma is related to raised serum cholesterol. It is not related to bilirubin. Remember, clubbing and skin xanthoma is related to raised serum cholesterol. And prolonged steatorrhea is related to osteomalacia. This is also known as biliary rickets. So biliary rickets seen in biliary atresia. In LFT you will see obstructive pattern of elevated bilirubin and ALKP, and there is a associated abnormality that include cardiac lesion, polysplenia, situs inversus, absent vena cava and pre-duodenal portal vein. So biliary atresia may be suspected parenterally when a cystic structure is observed in the porta hepatis of the fetal USG. This can be just a one-liner. So in congenital, that polyspermia word is important. And pre-duodenal vena cava, pre-duodenal portal vein is also important line. So in imaging and studies, fasting USG is the gold standard when biliary atresia is suspected, but this is Bailey line. In other books, if you see the gold standard word for biliary atresia, it should be the liver biopsy. So you will see in subsequent Sabiston and Schwartz this line. So shrunken gallbladder and hyperechogenic liver hilum. So triangular cord sign is seen in biliary atresia. Important one-liner. Triangular cord sign. So cyst at the liver hilum without bile duct dilatation. So there is a right hepatic duct, left hepatic duct and atratic gallbladder. So triangular cord sign. Okay, triangular cord sign. So MRCP is also highly sensitive and specific in the diagnosis, and definitive diagnosis by liver biopsy. Bailey says definitive diagnosis by liver biopsy. Okay, okay, and this is the triangular cord sign. Okay. So differential diagnosis include alpha antitrypsin deficiency, IV intravenous feeding, choledochal cyst, insipid bile syndrome. The most common differential diagnosis is Alageli syndrome. Okay, so it includes biliary atresia, congenital heart disease, skeleton other. So you will be asked, Alageli syndrome is associated with disease. So it is associated with biliary atresia. So it is the most important differential diagnosis. Important. A neonatal hepatitis is the most difficult to differentiate. Okay, okay. So in treatment, the medical treatment is medium chain triglyceride based feed. So it is medium chain. Okay, mostly in MCQ it will change long and short. So remember, it is a medium chain triglyceride based feed and fat soluble vitamin supplement. Medium chain directly absorbed. That's why it's a medium chain. Okay. And in surgical treatment for type 1 lesion, it is Roux-en-Y hepaticojejunostomy. Okay. And a simple biliary anastomosis is not possible in case of type 2 and type 3. So, Roux-en-Y of jejunum is anastomosed to expose the area of liver capsule above the bifurcation of portal vein. So, it is create portoenterostomy. Okay. So, achieving effective bile drainage after portoenterostomy as maximal when you do before age of 8 weeks. This is very important line, before you do 8 weeks. Okay, so bilirubin fall to normal, then the expected survival for that child is almost 10 years or more. Okay, and post op complication, bacterial cholangitis and hepatic fibrosis and portal hypertension. Okay, so if portoenterostomy is unsuccessful, you have to do liver transplant. Okay, okay. Few lines from Bailey only at different chapter. It is a congenital or acquired disease. Okay, so infection is associated with cytomegalovirus, but in Sabiston and Schwartz it is given rotavirus or reovirus. Okay, so it is a progressive obliterative cholangiopathy. Okay, and the type 3 is most common type. Okay, okay. Okay. And the late signs are malabsorption, growth failure, and coagulopathy. Okay, and diagnosis is confirmed with HIDA scan. Remember the keywords given. Okay, here it is given HIDA scan. So anywhere mostly ask with liver biopsy. So gold is standard, and the most confirmatory is with liver biopsy. Okay. So early diagnosis and avoiding sepsis may prevent irreversible liver fibrosis and death. Important line. And the treatment of choice is Kasai hepatico portoenterostomy. Important one liner. Old age golden question, means 1000 times asked. Kasai hepatico portoenterostomy done for biliary atresia. Okay. Okay. Let's see what is given in Sabiston. In Bailey, I forgot to tell classification. Okay, so this classification you may ask directly image based question. Okay, so you just see the type 1 is CBD, 2 is common hepatic duct, and 3 is right and left hepatic duct. Okay, so type 1 you see this CBD is atretic. Type 2A is that gallbladder is patent and the common hepatic duct is atretic, and type 2B is even gallbladder is obliterated, and 3 is everything is obliterated, right and left hepatic duct also obliterated. Okay, so now come to Sabiston. So it's obliteration of intrahepatic and extrahepatic bile duct. And splenic abnormality are asplenia or double spleen, both can be seen, absent in spleen or double spleen, and absence of inferior vena cava and intestinal malformation. Okay, so this disease is a progressive disease. Okay, there is a immune mediated inflammatory injury and subsequent obliteration of bile duct. So what are the pro-inflammatory cytokines related to biliary atresia? Interleukin 2, interferon gamma, and TNF. Okay, okay. As I said, rotavirus infection related to the immune process. Okay, and the clinical feature will be hyperbilirubinemia, jaundice, and acolic stool. Okay, and this is the picture of Kasai portoenterostomy. This is liver, and this is the jejunum. Okay, and this is the diagram. Okay, okay. So HLA B12 is related to biliary atresia. Just remember B12, BA. Okay, okay. Even CFC gene is also CFC1 gene also related to biliary atresia. Okay, the same classification. The classification is based according to level of proximal biliary obstruction. Okay, okay. Type 3 is most common, already told. Okay, so when there is a portahepatis involved, it is also type 3, important addition in classification. So type 1 and type 2 may be abnormal to direct extrahepatic biliary duct intestinal anastomosis. Okay, infant presents shortly after birth with jaundice, pale stool, and dark urine. Okay, so you may suspect the biliary atresia. In advanced disease, failure to thrive, hepatomegaly, and ascites from liver cirrhosis. Okay, so if jaundice is persist after 14 days of life in term infant, so evaluation for biliary atresia should be initiated, and you look for conjugated bilirubin level. Okay. Okay, this should be more than 2 mg per dl, and you look for torch infection. T for toxoplasmosis, O for then R for rubella, and C for cytomegalovirus, and H for hepatitis B and C, O for others. Okay, so in biliary atresia, gallbladder may be atrophic or absent. Okay, okay. So as I said, liver biopsy is gold standard for biliary atresia. Okay, and the hepaticoportoenterostomy Kasai procedure is surgical procedure of choice. So the most important line in whole chapter. Okay, so extrahepatic biliary tree is dissected proximally to the level of liver capsule, where portahepatis portal plate is transected. Okay, in medical treatment, apart from that you studied in Bailey, you can add ursodeoxycholic acid and phenobarbital also promote biliary drainage, and steroid after Kasai procedure has been advocated. Okay, so steroid pulse therapy is treatment option for post Kasai cholangitis. You can also add antibiotics. Okay, post operatively. Okay, okay. So Kasai hepaticoportoenterostomy does not cure biliary atresia. So this procedure can live up to 10 years. After that, you may need to do liver transplantation. Okay, okay. In just few lines in Schwartz, it is arrest of development during the solid stage of bile duct formation. Okay, there is a one syndrome called biliary atresia splenic malformation syndrome. Okay, okay. The perinatal exposure of reovirus and rotavirus. Okay, so syndrome often associated with polysplenia, intestinal malformation, pre-duodenal portal vein, and intrahepatic vena cava. Okay, okay. So absence of gallbladder is highly suggestive of diagnosis of biliary atresia. And biliary hypoplasia, that is Alageli syndrome, already told you. So one small topic, incipitated bile syndrome, when the bile ducts are normal but have persistent jaundice because of increased viscosity of bile and obstruction of canaliculi. So it is seen in infant receiving parenteral nutrition, hemolysis and cystic fibrosis. Okay. So first line therapy or treatment of choice for biliary atresia is a Kasai procedure. Okay. And then few bonus points from second fold, just few. Okay. So liver biopsy cannot differentiate biliary atresia from other disease including alpha 1 antitrypsin deficiency or parenteral nutrition associated liver disease. Okay. That biliary atresia and splenic malformation syndrome, BASM syndrome, and that Alagali syndrome is associated with JAG1 expression. Okay. So most infants clear their jaundice if operated on before age of 60 days. Okay. And the clearance of jaundice is defined as total bilirubin level less than 2 mg per dl at 3 months after surgery. Okay. And biliary atresia is most common indication for liver transplant in children, 1000 times asked. Okay. An indication for transplantation are persistent cholangitis, gastrointestinal bleeding from esophageal varices, and uncontrolled ascites and declining synthetic function. Okay, thank you.